Welcome along to this focused deep dive. We're aiming this one squarely at your MSRA pediatric revision.
That's right.
And today we are tackling a really key condition, pyloric stenosis.
Absolutely crucial.
Our mission really is to pull out all the high-yield stuff you absolutely need to know, make it easy to grasp, and hopefully memorable for your exams and, well, for practice later on.
Exactly. We're going deep into pyloric stenosis. Put simply, it's a narrowing right at the exit of the stomach. It's fundamental for pediatrics, and yeah, we'll throw in some mnemonics, some memory tips as we go to help make it stick.
Perfect. Okay, let's dive in then. Definition first. What exactly is pyloric stenosis?
So pyloric stenosis is basically the narrowing of the pylorus. That's the muscular bit, the channel between the stomach and the small intestine.
Right.
And this narrowing physically blocks food from getting through properly. That leads to those, well, classic symptoms we see in very young babies.
And where does it typically show up?
Usually it presents itself in the 2nd to 4th week of life. The core issue, the cause of the narrowing, is hypertrophy, basically, a thickening of the circular muscles in the pylorus.
Okay, hypertrophy thickening. And what actually causes this muscle to thicken up? What's the etiology?
Well, the exact cause isn't completely pinned down. That's often the case in medicine, isn't it?
True.
But the thinking currently points towards a mix of genetic factors and maybe environmental ones, too.
So it's not just one single thing, more like a combination.
Precisely. It seems there's likely a genetic predisposition, possibly several genes involved, and maybe hormonal factors playing a role in early development, all contributing to this muscle overgrowth, this thickening.
Interesting, the idea of multiple genes. Now, thinking about who gets it, are some babies more prone? What are the key risk factors we should be aware of?
Yes, definitely some clear risk factors. Being a firstborn male is a big one. They are affected much more often.
Okay, firstborn boys.
And the timing is pretty specific, too, usually showing up between 3 and 6 weeks of age.
Right, 3 to 6 weeks. Any other major associations to flag up?
Yes, and this is a really important practical point for you to remember. Exposure to certain antibiotics, specifically macrolides like erythromycin, very early in life, like in the first few weeks.
Wow. Okay.
That's been linked pretty clearly to an increased risk of developing pyloric stenosis. And finally, if there's a family history of it, that increases the risk too.
That connection with early antibiotics, erythromycin, that's definitely one to file away. Okay, let's get into the mechanics. What's happening physiologically? The pathophysiology.
So like we said, the absolute core of it is that hypertrophy, the thickening, specifically of the circular muscles in the pylorus.
Right.
This extra muscle bulk literally squeezes the channel shut, or nearly shut. It creates physical blockage, restricting food moving from the stomach into the intestine. And yeah, as we touched on, it's thought that genetics and maybe hormones kick off these changes in the muscle.
Okay, so the muscle itself gets too big and blocks the exit. Makes sense why that would cause symptoms. Now, before we get to those symptoms, what else could cause similar feeding issues or vomiting in babies this young? What's on the differential diagnosis list?
That's a crucial question, always. You've got to think broadly. Gastroesophageal reflux, GER, is incredibly common in infants, so that's high on the list.
Okay, simple reflux.
Then there's gastroenteritis, tummy bugs causing vomiting. Also really important to consider structural problems causing a blockage further down, things like intestinal malrotation or maybe atresia, where part of the bowel hasn't formed properly.
So other things causing vomiting, basically.
Exactly. You'd also think about GERD, gastroesophageal reflux disease, which is sort of more severe, persistent reflux. Sometimes it can just be feeding problems or an intolerance, like to cow's milk protein. And you absolutely must rule out other serious congenital bowel obstructions early on. Things like duodenal atresia, esophageal atresia, or crucially, intestinal malrotation, which can lead to an acute midgut volvulus that's a surgical emergency. So considering these alternatives is key.
That's quite a list to work through. So thinking about pyloric stenosis specifically, how common is it here in the UK? What's the epidemiology look like?
Yeah, in the UK, the incidence is roughly 2 to 5 cases for every 1,000 live births. So not super rare.
Okay.
And as we mentioned, there's that striking male predominance, about a 4-to-1 ratio, males to females. Firstborns definitely have a higher risk.
Right.
The way it runs in families suggests what we call polygenic inheritance, meaning multiple genes are likely involved in someone's susceptibility.
Okay.
Interestingly, it seems to be less common in populations with Indian, Asian, or Black heritage. Oh, and worth mentioning, it's incredibly rare in adults. If an adult has similar symptoms, you'd be thinking very different things, like gastric cancer, for instance.
Right, very different context.
Yep.
Okay, epidemiology covered. Now, the really practical bit for recognizing it. What are the classic clinical signs? What makes you suspect pyloric stenosis?
The absolute hallmark symptom, the one that should scream pyloric stenosis at you, is projectile vomiting.
Projectile.
Yes, it's forceful, often described as shooting across the room, and characteristically it happens about 30 to 60 minutes after a feed.
Wow, projectile vomiting.
Yeah.
That sounds quite unmistakable. Any tips for remembering that and the timing?
Yeah, think of a projectile being launched maybe 30 to 60 minutes after fueling up the feed. That timing is a really useful clue.
Okay, projectile after fueling, 30, 60 minutes. Got it. What else?
Well, alongside this dramatic vomiting, you'll almost always see weight loss, or at least failure to gain weight properly. This is despite the baby often feeding really well, even frequently. They just can't keep it down.
Right.
And kind of paradoxically, even though they're vomiting, these babies often show persistent hunger. They seem starving and will readily feed again soon after being sick.
Hungry, but can't keep it down. Poor things. What about on examination? What are we looking for, feeling for?
A key physical finding, if you can feel it, is a palpable mass in the upper abdomen. This is that thickened pyloric muscle.
Ah, the famous olive.
Exactly. It's classically described as feeling like a small, firm, movable olive.
Right, I've heard that description. Where exactly would you try and feel for it?
Usually in the right upper quadrant of the abdomen, or maybe the epigastrium, sort of just below the ribs in the middle. It's often easiest to feel when the baby is relaxed, maybe just after they've vomited. There are specific techniques to help palpate it.
Okay.
And of course, because of all the vomiting, you need to look for signs of dehydration. Things like a dry mouth or dry nappies, reduced urine output, maybe sunken eyes or a sunken fontanelle, that soft spot on the baby's head.
Makes sense.
Also, the vomiting usually gets worse over time, becoming more frequent, more forceful. And while it's usually in those first few weeks, presentation can sometimes be later, maybe up to 6 months, though that's less common. Oh, and sometimes you might actually see waves of peristalsis moving across the baby's tummy wall as the stomach tries really hard to push milk through the blockage.
Okay, so projectile vomiting, weight loss despite hunger, the palpable olive, dehydration signs. Those are really key clinical clues. So if we suspect it based on those, what's the next step? How do we confirm it? Investigations.
The gold standard, the primary investigation, is an ultrasound scan of the abdomen.
Ultrasound, okay.
Yeah, it's non-invasive, readily available, and it lets us directly see the pylorus. We can measure the muscle thickness and the length of the pyloric channel to confirm if it meets the criteria for pyloric stenosis. It's very sensitive and specific for this.
Ultrasound first line, great. What about blood tests? Do they play a role?
Yes, blood tests are important, but mainly for assessing the consequences of all that vomiting before surgery.
Oh.
We need to check the baby's electrolytes, things like sodium, potassium, chloride, bicarbonate, and their kidney function, and generally assess their hydration status. This tells us how metabolically deranged they might be before we think about surgery. It guides the pre-op fluid management.
Got it. So ultrasound confirms the diagnosis, bloods check the baby's overall state, right? So we know what it is, how to spot it, how to confirm it, how do we manage it, what's the treatment?
The definitive treatment is surgery. It's an operation called a pyloromyotomy.
Pyloromyotomy.
Yes, essentially the surgeon makes a small cut along the length of that thickened pyloric muscle, carefully splitting the muscle fibers down to the inner lining, the submucosa. This releases the constriction, opens up the channel, and lets food pass normally from the stomach into the intestine again.
Okay.
The classic, most common technique is called Ramstedt's pyloromyotomy. It's been around a long time and works very well.
Okay, surgery to split the muscle. What about before and after the operation? What care is involved?
Hugely important point. Before surgery, you absolutely must correct any dehydration and electrolyte problems caused by the vomiting. That's done with intravenous fluids, IV fluids. You need the baby to be stable before they go for surgery.
Right. Stabilize first.
Exactly. Then, after the operation, the baby needs close monitoring. We watch how they tolerate starting feeds again, check they're having bowel movements, just monitor their overall recovery. But the good news is most babies can start feeding again pretty quickly, often within hours, and get back to full milk feeds relatively fast after a successful pyloromyotomy.
That sounds positive.
Yeah, and just to mention, keyhole surgery, laparoscopic pyloromyotomy, is also an option in many places now. It's just as effective and might sometimes allow for an even slightly quicker return to feeding.
That all sounds very effective. What about the long-term outlook for these babies? What's the prognosis generally like?
Generally, the prognosis is excellent. Assuming it's diagnosed and treated promptly with surgery, the vast majority of babies make a complete recovery.
That's great news.
Yeah, the symptoms resolve completely. Mortality is very rare these days. It really only happens if there's a significant delay in diagnosis, leading to really severe dehydration and its complications.
That is very reassuring. Are there any potential complications we should know about, though? Things that can go wrong?
Well, yes, like with any surgery or medical condition, things can happen, although thankfully they're not common with pyloric stenosis treatment. The main risks, especially if diagnosis is late, are those dehydration and electrolyte imbalances we talked about.
Right, from the vomiting itself.
Exactly. Then rarely you can get surgical complications, maybe some bleeding, an infection at the wound site, or scarring. Very occasionally, the pylorus might actually narrow again after the first operation, which would need further surgery.
A recurrence, okay.
Yeah, it's rare though. And finally, there's an extremely rare thing called foveolar cell hyperplasia, FCH. It's a different kind of cell overgrowth that can cause ongoing obstruction even after a standard pyloromyotomy and might need a more extensive operation. But again, very uncommon.
Okay, so overall, a really good outlook with timely treatment, but good to be aware of those potential, albeit rare issues.
Right. Let's try and summarize the absolute key take-homes on pyloric stenosis for everyone listening, especially for revision.
Okay, key points. Think narrowing of the pylorus in young infants, usually firstborn males, typically presenting at 3 to 6 weeks. The absolute classic symptom is projectile vomiting, often 30-60 minutes after feeds.
Projectile vomiting. Got it.
Look for that palpable olive in the upper abdomen on examination, a key sign if you can feel it. Ultrasound is your go-to investigation for diagnosis.
Ultrasound. Check.
Treatment is surgical Ramstedt's pyloromyotomy after correcting any dehydration and electrolyte issues. And the prognosis, excellent with timely treatment. Oh, and don't forget that link with early macrolide use, like erythromycin.
Fantastic summary. And those memory tips, the projectile launching 30-60 minutes after fueling and remembering the palpable olive, hopefully those will help lodge it in your memory.
And just before we finish, for more fantastic MSRA preparation resources, do check out pastmsra.com and also freemsra.com. They are genuinely invaluable tools.
Absolutely agree. Look, really getting to grips with common pediatric conditions like pyloric stenosis isn't just about passing exams. It's fundamental knowledge for providing really good, safe care when you're looking after children. It builds that foundation you need.